week rotating cycle. Today is the second week. Last week, we really talked about, Dr. Maley and I kind of went over just the landscape of opioid use disorders, the current epidemiology, the current treatment landscape. So this is our sort of second core session that we do each time in this 12-week cycle. And the idea today is to introduce our FDA-approved medications for opioid use disorders, right? So we're gonna just introduce them, talk a little bit about them, bird's eye view, before we start honing in on them, starting the third session, right, which will be next week. So we're gonna begin with, and I'm gonna just start the slideshow here. And this is the continuing medical education CME, CEU information that's included here for you guys. And as we begin, as always, there are no financial disclosures to make regarding the contents of this activity. This project, of course, is funded through AHRQ, Agency for Healthcare Research and Quality, so no industry funding here. And in terms of the, for me, in terms of, because I will be talking about medications, including Buprenorphine and Naltrexone, and while we are involved in clinical research with those studies are funded, again, through either through National Institutes on Drug Abuse. So there is no financial arrangement, no industry relationship to report regarding the contents of this activity. So we're gonna, just provide an overview. It's exactly what it says, right? It's an overview of our FDA-approved medications for opioid use disorders. So we're gonna go right into that with this. So we're gonna become familiar with the 3 FDA-approved medications for the treatment of opioid use disorders. And really, I wanna talk about, like, how do you help your patient choose between these treatment options? And that's what I was hoping. If there is no case, if someone has a case at the end of this, of course, that takes the priority. But if not, I thought we can spend some time really talking about different scenarios and how do you choose between one versus the other? How do you walk a patient through it? So, maybe we'll have a discussion on that and start to develop comfort. And the third objective is really something we start today and hopefully carry through the entire 12-week cycle, right? Is starting to gain that comfort, that confidence that, that I can work with a patient who's on medications for opioid use disorder. So this is the section, this talk, each cycle, I start off with this particular slide, this particular data, because it is very important. Very often when we think about treatments, medications for opioid use disorders, we think about detoxification, right? We think about that 5-day detox, that maybe that 10-day detox where the person goes, or maybe they go to the emergency department and get a quote unquote kick kit to help them detox from heroin. And, we sort of think about that, but data really does not support detoxification as a treatment for opioid use disorder. That much is clear. And that's something we've known for a long time, that detoxification can be a part of treatment, but by itself, it is not treatment. And this is a quote from Dr. Walter Ling at UCLA. And I just love this quote. I just think it really captures what we know about detoxification, which is that detoxification from heroin is good for many things, but staying off heroin is not one of them, right? And detoxification alone has never been shown to improve any long-term outcomes. And yet often we think about that detoxification or that drug-free approach when we think about opioid use disorders, right? That's in many ways the traditional model that we've seen in the United States over the years. And it may actually be effective. Does it not work for anyone? Probably not. It probably is effective for a small subgroup. If you look at the data, and I was reviewing this again recently, just to see, just to kind of catch up on it, just to brush up on it. And what I really found is that, in some studies, you actually find about a 10 to 20% of people with opioid use disorder who detoxify and just do fine and never return to using any opioids and never, have a relapse and never have a recurrence of use. Some studies peg that number at well under 10%, but there are some studies which go up to even up to 20%, right? So it may be effective for a small subgroup, but there is no good data. There is no way to predict who might that be, right? So again, I tried to delve into the literature to see, can we predict who those people might be who never go back to using illicit opioids after detox, and there is no way to know, right? So it's essentially a flip of a coin, but not really, right? Because if you were just flipping a coin, it would be a 50-50 chance. Here, the chance is at least 80%, maybe even 90% or greater, that the person will return to using illicit opioids, and everything that comes with it, right? Hepatitis, HIV, overdoses, cellulitis, compromising relationships, compromising of work, spirituality, all of those things. But in general, we seem to think that those are people who are highly motivated, maybe have stable social relationships that encourage people to not use, that are supportive, that people can talk to. But otherwise, generally up to 90% of people who have been detoxified relapse within the first month or two. And it just gets worse from there, right? And this is a classic study here done by Kako, published in the Lancet, which is a very prestigious peer-reviewed medical journal way back in 2003. And many of you who are ECHO regulars have certainly seen this slide before, right? Because we present it in each 12-week cycle. So these are all individuals with opioid use disorders. And what Kako did is that they were randomized in two groups. The group with those red circles are the people who are maintained on buprenorphine. So they got started on buprenorphine and maintained on it. And the green square are randomized to detoxification. So they were detoxed for 1 week and then given placebo. So they still gave them placebo, right, to kind of challenge it out. And they were followed for 1 year. And what you find is that the group that was actually given buprenorphine for a year, about 75% of them were in treatment 1 year later. And that's important because every study done in the 21st century has shown that the more you can keep someone in treatment, the better they do. And makes sense, right? Because when people are in treatment, that's when we can do all those wonderful things we do, like make sure they have stable housing, support them with whatever their needs might be with employment or relationships, teach them relapse prevention skills, work with them so they can become more productive members of the community, treat their PTSD, treat their Hep C. If they're not in treatment, we can't do any of that. And that's what happened to the people who were detoxed and given placebo. You can see that within just 2 months, every single participant had dropped out of treatment. And when they were followed up 1 year out, everyone in the buprenorphine maintenance group was alive. And the group that was detoxed, 4 out of 20, in other words, a full 20% of that sample, that group, was no longer alive. And that's just in 1 year, right? And that's been shown again and again and again that our medications for opioid use disorder, specifically methadone and buprenorphine, save lives, right? And that's been a consistent finding. So I think that brings me to the role of medications. And that concept has really evolved, right? For a long time, we used the word, and we still do for this ECHO, because that's sort of the approved name for it, which is the medication-assisted treatments, or MAT, and it makes for a good, catchy acronym, right? But I do like to point out when I do this talk that the data is really shifted to say that, when it comes to opioid use disorders, medications actually play a central role, right? They are if you just provide other treatments, other psychosocial treatments without medications, outcomes don't necessarily improve, and the medication is really needed. And that's different, right? Even compared to other substance use disorders. Like if I'm working with a patient with stimulant use disorder, or if I'm working with a patient with cannabis use disorder, right? Then what I wind up saying is that our psychotherapies are what's gonna help you. That's where the evidence is. If I'm working with a patient with alcohol use disorder, then I tell them that we've got these medications that help, and we have these psychotherapies that help, right? If I'm working with someone with post-traumatic stress disorder, then I wind up saying it's the psychotherapies that are gonna help you far more than medications. But when I'm working with a patient with opioid use disorder, the message I give is that it really is the medication that's going to improve a majority of the outcomes. So over the years, that's shifted, and the term we've started using now is MOUD, or medications for opioid use disorder, right? I started with methadone outcome because methadone, which is one of our FDA-approved medications for opioid use disorder, has been around the longest and so has been studied the most. Right? It's been around for about 5 decades in the United States. And these are just some of the data that have been shown with it. Reduction in heroin use by conservatively 50%. In many studies, that number approaches 70%, 70 to 80% even in some of the studies, right? Reduction in HIV by fourfold, increase in employment, reductions in criminal activity, less incarceration, less high-risk behaviors, more child support payments, more likely to stay in treatment, improved adherence to Hep C treatment, cost effectiveness, and mortality reduce. In general, what we seem to think is that compared to someone without opioid use disorder, someone with opioid use disorder who is not in treatment is about 6 times more likely to die as a result of that opioid use disorder. And when they're maintained on either methadone or buprenorphine, both seem to work about equally well with it, that risk of dying comes down to about 1.8 times the general population. So significant reduction in mortality has been observed, right? And again, improvements in all of these high-risk behaviors have also been shown in a Cochrane review with methadone, right? This was one of the studies, old studies, and our site, UNM ASAP, where Dr. Maley and I both do our clinical work, is one of the sites here, showing that when people were placed on MMT, which is methadone maintenance program, their risk of engaging in criminal activity dropped off significantly, which may go against sort of the popular belief or the popular narrative, but that really has been what's shown, right? And just some other thoughts is that medication, while it's central, it's often the hook that allows us to then provide more comprehensive treatment and do all those wonderful, magical things that all of you guys do, right? In your own, as peer support specialists, as psychotherapists, as social workers, as front desk staff, right? Whatever that might be. But that as if our patients are coming in, it allows us to do all of those things. It allows us to treat those underlying illnesses, both physical as well as emotional, psychological, allows us to start to help stabilize life through employment, housing, those social networks, right? They're key. In study after study, you see the importance of those social networks. Does your community support you? Does your community bolster you, prop you up, support your strengths? Or does it sort of lead to more stress, more trauma, and maybe even encourage substance use, right? And also things like coping skills, relapse prevention strategies, emotional regulation, all of those. So with a little bit of that data, right, let's kind of talk briefly about our FDA approved medications here, right? And we'll start with methadone. Methadone has been around the longest. Methadone has a long storied history. It's actually been used as an opioid analgesic since the 1930s. It's a bit of a dubious history, actually, where it was invented in Nazi era Germany as an analgesic, and then came to the United States, following the end of World War II, and really was the first medication that was explored for treatment of opioid use disorders. And the two providers credited with it are Dr. Marie Niswander and Vincent Dole, who really started exploring methadone. And they're like really synergistic, interesting backgrounds, where Dr. Vincent Dole had done all of his work with diabetes. He was basically a diabetes researcher and had this idea that if I have a patient with insulin-dependent diabetes, I can't cure the diabetes, but as long as the person receives insulin, I can prevent all those things like, nerve damage and kidney damage and eye damage. Meanwhile, Marie Niswander had been working with people with addictions in the Bronx, I believe primarily in New York. And she said, hey, you know what? This might really help my patients. So things got started, data started coming out, and showing that it was saving lives. It was keeping people from contracting HIV, and it really became a part of our system. It is a Schedule II medication, so it's highly regulated. And if methadone is going to be used for treatment of opioid use disorder, it can only be prescribed from what's called a narcotic program treatment setting, more formally known as opioid treatment program, colloquially known as a methadone clinic, right? And that itself poses a barrier because, the number of slots in opioid treatment programs has remained relatively stable in the last 20 years, even as the opioid epidemic has raged. There are parts of the country, right, even parts of New Mexico, where there are no opioid treatment programs close by, right? And oftentimes when someone starts methadone maintenance treatment, they're going to be required to go into the clinic on a daily or near daily basis. So if the clinic is a couple hours away, you can see how quickly it can start to create a barrier to treatment. It is a full mu agonist. So the higher the dose, the more it impacts that opioid receptor and activates it. At the same time, it has a weak affinity. So it binds those opioid receptors not very strongly. So if something else with a higher affinity comes along, it's going to kick methadone out and take its place. I think some of the challenge, I've talked about the treatment barriers with methadone. I think some of the other challenges become that you have to be very careful with medication interactions. It can certainly be dangerous or even fatal in case of overdoses, right? And you also have to monitor the heart, the EKG closely. So because of those reasons, really in the 90s, we started turning to buprenorphine. We started saying, can buprenorphine help bolster our treatment system? Because the majority of patients with opioid use disorders, even in the 1990s, were unable to access treatment. So we turned to buprenorphine, which had been used in Europe since the 80s as a treatment for opioid use disorder. And buprenorphine is just a lot safer in terms of overdoses, in terms of medication interactions, in terms of its effects on the heart. So it's a safer medicine. So we started saying, or not me, right, but we as in a collective community of providers and medical professionals started saying, can we explore buprenorphine as an effective treatment and really improve access? And sure enough, the consensus was yes. So in response to it, the Congress passed the DATA 2000, which is Drug Abuse Treatment Act, which allowed for office-based prescribing of Schedule III opioids to treat opioid use disorder. And that paved the way for FDA approving buprenorphine as a treatment for opioid use disorders. And it set up a training requirement. At that point, it was physicians alone saying, if you're a physician, you can complete an 8-hour training and get what's called an X number, which is a new DEA number, and then you can start treating a limited amount of patients with buprenorphine, right? Up to 30 patients in the first year, then go up to 100. But access problems remained, as we talked about last week. So in 2017, the CARA was passed, the Comprehensive Addiction Recovery Act, I believe. I'm horrible with acronyms, so if I said it wrong, feel free to chat in the correct name for CARA, which allowed nurse practitioners and physician assistants to also prescribe buprenorphine, but with a 24-hour training, and expanded that limit for physicians to 275 patients. And then even after that, a couple of other things have happened. The Support Act expanded the prescribing to nurse specialists, nurse anesthetists, nurse midwives. And most recently, as we talked about last week, this slide was I'd included last week, is the new order from Secretary Becerra from the Health and Human Services, which now says that, hey, you can apply for your X waiver even without doing these required trainings. But if you do that, you're going to be limited to 30 patients. So it certainly relieves a barrier, but I still think there may be value in doing a training because it allows you to treat more patients, and it also gives you the confidence and the clinical knowledge necessary to provide treatment that meets standard of care, right? So we're going to keep doing trainings. We don't make any money from it. So no disclosure there, but we're going to keep offering them in sort of one of our missions, which is to support new providers, right? So buprenorphine is a partial agonist. So after a certain dose, it hits a ceiling. And that's really what makes it so much safer from overdose. There are also, generally is taken as a sublingual film or a tablet, but there are also implants and a long-acting injection. In fact, new longer-acting injections are about to be FDA approved in the upcoming months. So we'll have many, many more options, right? So what are some benefits of office-based treatment? We go into, again, the nitty-gritty of buprenorphine as we work through our 12 weeks. So today is the overview. So I want to again, so why think about office-based treatment? What are the benefits of not having to go to an opioid treatment program? Some people certainly benefit from that structure provided by an opioid treatment program. Many patients benefit for it, but for many other patients, that option, right, of having that private, confidential, safe treatment provided in your normal provider's office, right? The continuity of care, that connection with your provider, right? Being able to stay in your community, having that time available for work, family, other activities are really important. And it ultimately improves access. And compared to methadone, it's about as effective in terms of treatment retention, in terms of reducing opioid use, in terms of mortality reduction, has certain benefits. It's a lot safer, but generally has less treatment retention compared to methadone. And again, I think it's because there's a subset of patients who may just benefit, right, from the structure provided by methadone maintenance treatment. So that's methadone, that's buprenorphine, and naltrexone is our antagonist treatment. Naltrexone essentially is something that blocks your mu-opioid receptors, right? So if someone is on naltrexone and they wind up using an opioid, nothing will happen. There will be no reinforcement. They won't get high. So over time, they stop using that illicit opioid. Naltrexone comes as a daily oral pill as well as a monthly injection. Both are FDA approved for treatment of opioid use disorder. However, research does not support the use of daily oral pill of naltrexone to treat opioid use disorder because people simply don't stay on it. So if you're going to use naltrexone to treat opioid use disorder, think about using the injection. Some recent studies have in fact shown that for many patients, naltrexone can be just about as effective as buprenorphine, but the big challenge that we still haven't figured out is that it's so much harder to initiate compared to buprenorphine. You gotta wait at least 7 to 10 days without using any opioid before someone can start naltrexone, and that creates a huge barrier. And many patients leave before ever starting treatment. And we still haven't come up with a great solution to that, despite lots of research. So how do we choose? Right? So I've included some slides, and this is courtesy of PCSS Providers Clinical Support System, for which I serve as a trainer. Right? So naltrexone, I think in general, we think about using. There are some patients who just don't want to be on an opioid, or they are not able to be on an opioid. For example, those who have a high degree of motivation for abstinence-based treatments. We have some people who are super connected to 12-step, and they just don't want to be on an opioid. Or they're in a profession where treatment with buprenorphine or methadone is just either controversial, as it says here, or even not allowed. For example, physicians or commercial pilots, and naltrexone really becomes an option. The time when I use naltrexone the most is this bullet. Patients successful on agonists, but who wants to try abstinence. So we have patients, in fact, I'm working with now, who's been on methadone, but has been gradually tapering off. They're down to now that last little bit of methadone, and they're doing well. They're still not using illicit opioids, but they're starting to get a little bit scared. What happens when I go off of methadone? So the strategy, one of the strategies we discussed, in fact, last week, was saying, how about once you're off of methadone, we'll place you on the once-a-month injection of naltrexone for a couple of months, 2 months, 3 months, while you work on your relapse prevention skills, while you work on your confidence, there's just that amount of confidence you feel in terms of being able to stay away from opioids. And once you're ready, we'll just take away that naltrexone, right? The other big one is patients who are abstinent, but at least for the risk of relapse, that last bullet. So we have patients who are not on an opioid, they've tapered off of methadone or buprenorphine, they haven't relapsed, but maybe they're moving to an old neighborhood, or they're going through increased stress and they're worried. And we say, why don't we place you on naltrexone for a while until things smooth out? Who are good candidates for, buprenorphine or methadone? So in fact, what we know is that patients with a history of multiple overdoses, particularly following detox, may be better candidates for methadone and buprenorphine because they're much more robustly shown to reduce the risk of future relapses. Patients with serious mental illness who are disorganized, who are dealing with houselessness, actually do really well with methadone maintenance treatment because they go in for their methadone, right, on a daily or near daily basis. And that's when we can make sure they see a case manager, they see a provider, they get their injectable antipsychotic, They see a therapist, so everything can nicely be organized, right? So the structure can really benefit them. Patients who have chronic pain require chronic opioid treatment. In that group, I think about buprenorphine as being the first line treatment, as we'll talk about in one of our future modules, followed by methadone. But in this group, I'd certainly want to avoid the use of naltrexone, because if they're on naltrexone, opioid analgesics will not be effective, right? For pregnant women, the data for naltrexone is still not to the point where we can recommend it. There's growing data, but for pregnant women, we think about buprenorphine and methadone. Again, things we'll cover as we go through our 12 weeks. And of course, patient choice matters. Involve our patients in that. And then for more directiveness, I've here included this reference slide to compare buprenorphine and methadone. So just think about that. And I'll end with this. How long do I stay in treatment? And my answer is for as long as it benefits the treatment, right? So we try to maintain patients in treatment for as long as possible. And we really encourage them to not stop treatment too early. And if you're able to, there's a great role for integrated clinics, right? So integrating primary care, behavioral health, treatment for opioid use disorders and other substance use disorders, right? If you're able to achieve that either within your own agency or through collaborating closely with other agencies in your area, you can really help and improve outcomes. So I will end here, Rana, and I will stop sharing.